Um, okay, everybody, thanks for coming to this webinar here today. Today is January 15th, 2025, so it's our first webinar of the year. For those of you who are watching this at home, two quick notes. Number one, turn your volume up if it's not up. Number two, click the Q&A button to ask any questions. You can type your questions right there into the computer. I will wait to the end to answer all the questions, but let's get started. The purpose of this is to really understand how stem cells solve pain, and that's what we're all about here at Richard Kim Medicine. Here's the first question and answer. It's from Bev W. at area code 514. Looking forward to learning more about your process, efficacy of the solution, and to learn more about your Plattsburgh location. And what exactly is then regenerative medicine? That's what we hope to answer here for you, Bev. Here's another one for Carmen. Carmen from 845, explanation of the various injections you do offer for pain. So we are a regenerative medicine practice, and the focus of what we do is for different areas, back, neck, knee, hip, and more. Under the name of regenerative medicine, there are different things that we can use and apply, and so we'll get into some of that here. Let's start off with what our common goals are. Our common goals as patients are, as doctors are. We all want pretty much the same thing. Number one, we want to avoid surgery, and number two, we want to stop medications. Of course, if there are more sort of harmful medications like opiates and medications that we're dependent on with some not so great side effects, these are things we want to stop. And the last thing we want is quality of life. We may, through our pains, have realized we're losing a certain quality of life, and we want to try to regain that and bring that back as much as possible. Our common goals are we want to certain things within these common goals. We want the doctor or the someone who is taking care of us to have a plan. We want that plan to be safe. What does that mean? We want something with low risk, short recovery, and we want to be able to avoid any pitfalls, and we want to be able to return to our activity without a whole lot of risk. Here's two good examples of patients of ours that have undergone the process. Number one, a retired psychologist who flies airplanes for a hobby, was a runner, competitive, but also did it for stress relief. The back pain ended his running, meant no more competition, no more fun, no more stress relief, really limited the flying time. The chef is the second person spending time with family. This meant constant motion. This also meant moving heavy restaurant equipment. This pain was really affecting his work. It made working difficult from day to day, to the point where he was contemplating changing careers. A lot of times, conventional medicine misses the target. Our traditional treatments have limits. Surgery, we understand to be permanent. It's invasive, usually requires a long recovery, and then therefore is not that easy to think about sometimes and really sort of unwanted. The other thing is medications, and these typically fall under two categories. Number one, steroids, which can be a band-aid, but they can weaken and they can damage tissue, whether you take this orally or you have this injected. Therefore, repeat steroids means repeat weakening and repeat damage of that area. And then the second, we have these over-the-counter medications in which we can, very casually reach for when we feel the pain. And of course, these can lessen their symptoms, but the effects wear off, which means now you've got to reach for them again. You've got to repeat the dose, and oftentimes we can then become dependent on these medications. 2 months after stem cell therapy, our psychologist was returned to running. Ran the 4th of July race here locally. It was a 4-mile race, ran a 13-minute pace. It wasn't his favorite pace, but happy to do it. This gave him the confidence to train for a half marathon with his grandson, and that was an important goal for him. The chef was back at work full time, able to provide for his family, which is important. So how exactly do we do this? And what we do is we break the cycle. When we often endure pain, that then leads to degeneration, and then degeneration leads to further pain. And then, of course, we get caught in this pain loop. We are the third solution. We are neither surgery, we're not medications. What we have is something with a high success rate, something that does give you years of relief. So, unlike things like medications, which may last a few hours to a few months, and what we have is guaranteed acceptance. The cells come from you. Our therapy utilizes cells, and these cells come from you and back into you, and therefore you can't reject them. But what exactly is regenerative medicine? It's a new field of medicine, and the focus here is to restore and not replace tissues. When you think about damaged tissue, we want them to turn or transform into something healthy, something functional. We use different materials in order to make this happen, platelets and stem cells. If you can imagine the green and the yellow circle there on the slide, those are our small and medium-sized problems. Let's say yellow and red is our medium to large size problems. Here's a good video of what actually happens to the cells. Where the red is bad, damaged tissue, the green is good. So the green cells come in and invade the damaged tissue. That red is what we interpret as pain, stiffness, sciatica, nerve pain, neuropathy, numbness, shooting, aching, grabbing type pains. Here's another example of how I like to describe this. If the pellets within the game of Pac-Man are the inflammation, Pac-Man eating one pellet at a time is similar to platelet-rich plasma therapy, where if you were to put multiple Pac-Man into the screen at one time, that would be like stem cells. The goal here is not to get to the next level, like traditionally in Pac-Man. Our goal is to leave the game behind entirely, stop playing this inflammation develops and then get rid of the inflammation game. How well does this work? Well, this works from, depending on what we're treating, anywhere from 5 to 10 years worth of relief. And we'll get into this a little further. First, let's talk a little bit about where the cells come from. For us, the stem cells are something that we extract from you. So, for example, we're extracting them from the bone marrow, and we'll take that, we'll process that in that large black arrow there, and reintroduce it into degenerative areas. For example, in the degenerating disc of a spine, or a knee, or a hip. This is our typical timeline and schedule for when we apply these therapies. We always like to start off with a consultation. We like to know what it is that you're looking for, what you hope to achieve, what you plan to achieve through this process. Plus, it's important for us to understand how severe your problem is. Is it mild? Did it start a week ago? Did it start 2 decades ago? Soon thereafter, we're going to be working on obtaining an MRI, and of course, for us, an MRI is in-house. We are looking to perform our first procedure, which is the first PRP, and then soon thereafter, the second PRP and the stem cell, and then the third PRP. Typical time range between the first and the second is PRP and stem cell is 2 weeks, and then from 2 to 3, typically about 4 weeks. Once we're done with the injections and physical therapy, chiropractic care is what we start, and that can last anywhere from 4 to, in some people, 8 to 12 weeks. Everybody's a little bit different, but we do ask for a standard 4 weeks. What kind of things can we treat? Well, a lot of what we see is what's prevalent out in the community, out in the world. So we do see a lot of people asking us for about stenosis, arthritis, degenerative disc, sciatica, especially when it comes to neck and back issues. In the lower body, arthritis, when we hear the words bone on bone, this is typically what we're talking about. Bursitis, meniscus damage, anything from the tendon, the ankles, the feet. What about in the upper body? Rotator cuff, shoulder arthritis, tennis elbow, carpal tunnel. These are just to name a few. What's important for a lot of patients, even before they ever arrive, is they want to know, yes, but am I going to be a candidate? And the way I like to think about this is in this explanation to people. If it's something that we can inject, for example, if people can inject it with a needle with steroids, I can get that same needle there to that same location and apply stem cells. For example, if it's something that can also be operated on, I can also apply a needle to that same area and apply stem cells. For us, it's always important to start off with the right diagnosis. An accurate diagnosis means accurate location, which ultimately means an accurate therapy. And in part of obtaining an accurate location in therapy and diagnosis, we always include an MRI as part of our process. And therefore, I also encourage you, if you're looking at either regenerative therapy or stem cell therapy, be sure that they're performing an MRI so that they're not just guessing where to apply the stem cells. What if you've had surgery? Yes, important thing to note is that soon thereafter we're going to need a consult. Even if you've had surgery, we still need a diagnosis. We still need to obtain some imaging. The history, the exam during our first meeting is going to be important. It's going to be critical. The type of surgery you've had is important. Was it an arthroscopy? Was it a fusion of the spine, a rotator cuff surgery? These sort of pieces of information. How about some frequently asked questions? Where will my stem cells come from? So I showed you previously in that prior slide that stem cells can come from the bone, the back of the pelvis. We also do utilize adipose type tissue, which is fat. And so that all really depends on what we're treating and when we're treating it, level of severity. How long before I can become active? We're talking about anywhere from that third injection on. So after PRP number 3, if you recall, you can then become quote unquote normally active. For those of you who are watching this and saying, "Oh, I forgot what that chart looked like," this is recorded and will be shared in the future, and therefore you can always rewind to that. When do you typically feel the benefits? So again, between injections 2 and 3, I would probably say 60 to 70% of the time, people begin feeling the differences there. Some people take a little bit longer. And again, chronic disease, prior surgery, all of these things may contribute to that. Next question of how long will the tissue stay repaired? So depending again on what we're treating, anywhere from 5 to 10 years. I would say joints were typically closer to 5 to 7. And then when we're talking about necks and spines and low back, we're talking about 7 to 10. How well does this work? It depends on the patient. It depends on the severity. Depends on whether or not you've had surgery. So this one is really harder to answer and really more individualized. Let's get to some of our questions here. First Q&A is from Donald B. from area code 315. Can this process help with degenerative neck, disc, and related back pain? So the answer is yes. Degenerative disc disease is something we like to describe as a problem where the jelly is leaving the donut. Stem cells when we inject stem cells into the donut or into the disc, we're rebuilding that donut, and that really means helping keep jelly within the donut, which also means a better functioning donut. And this is something we can apply to the neck as well as the low back, and virtually anywhere along the spine. So we've actually have been able to do it in people in the thoracic spine. Obviously, meeting you, Donald, and being able to see the level of which levels are effective and how badly are they affected is an important thing for us. Martha S. from 315 said, stem cells for arthritis, stem cells for degenerative conditions, discs, etc., efficacy and options. So, right, when it comes to arthritis, degeneration, spondylosis, stenosis, a lot of these sort of terms are what we're going to hear when we see degenerative discs, and a lot of these things travel together. where we are the non-operative solution. And to give you an idea of efficacy, we're talking about something that lasts anywhere from 6 to 10, or anywhere from 7 to 10 years in terms of a level of efficacy. So an incredibly effective option, helps you stay away from the surgeon, helps you stay away from the injections, and through simple maintenance of exercise and active living is all you need to do in order to maintain that. Carol K from area code 841 said non-surgical approaches to pain in my back. And we have a little guy standing there with three arrows. So our therapies really help anybody when we're talking about pain in the back from mild to severe. Our methods are non-surgical. They're all done in the office. Nothing's done in a hospital. Nothing's done with general anesthesia. And again, talking about that 7 to 10 year efficacy. For you, Carol, I would certainly recommend the consultation as the next step. Let us review you, let us review your history, your exam, and as well as any imaging that you might have. Jeff C. from 518 said, I'm interested in this as a treatment for my cervical radiculopathy instead of fusion surgery procedure. I'm located in Saratoga Springs. So that's one of our offices, and where I'm broadcasting this webinar from today. So for you, Jeff, and for everybody out there, what a cervical radiculopathy means is that when you have a problem in your neck, oftentimes a pinch of a nerve, and that pain then travels all the way down, and sometimes even into the fingertips. And now people can have that same radiculopathy in your low back, and of course, then it travels down all the way down to your legs, or sometimes even to your toes. That picture there is an example of what a fusion is. Basically, they're taking metal bars and screws and then placing them into the vertebrae or into the bones of the spine, therefore trying to limit the motion between the bone that's been fused above and the bone that's been fused below. The question you might ask is, well, aren't you supposed to have flexibility there? And the answer is yes. So when you fuse something, you're going to have permanent loss of flexion at that level. That means that the disc above it and then the disc below it are forced to compensate. They have to both pick up 50% of the flexion lost in the fused level. This oftentimes leads to sped up degeneration of the level above and below. We call this adjacent segmental disease. This may also be why you hear that when people have fusion, a couple of years later, they need another fusion, and a couple of years later, another fusion after that. Now, if you've had fusion, is this something we can help you with? Yes, absolutely. If you've never had a fusion, it's something we can also help you with in order to help avoid fusion altogether. So our therapy requires no hardware, and then is effective in 7 to 10 years. You get to keep, in a sense, your neck or your back. Mary Z from area code 514 said, I want to understand stem cell. I had level 408 in both knees and would love to avoid surgery to replace both full knees. So the answer to that is level 4 osteoarthritis of the knees. So level 4, for those who don't know, is just sort of the highest level of degeneration. Just recently, a couple of weeks ago, we had a patient who did stem cell on both level 4 OA knees and came back pain-free, and is able to walk. And she had a significant amount of bowing in her legs and all of this, but doing incredibly well. For a knee like this, we're talking about a potential repeat situation in 5 to 7 years. Obviously, every patient being different, we'd certainly like to meet you, Mary, and discuss your knees and see how they look and what we can do about it. Terry D from area code 514 says, does this help knees with arthritis? And similar to the patient before, yes. So important thing is to discuss our timeline. As you're from the 514 area code, we're going to have to talk to you a little bit about how are we going to accomplish these 3 injections between our Plattsburgh office and Saratoga office. And this is something we like to review during the consultation. Eric L. from 518 said, treatment for injury, torn tendon, bicep. So this is important where you have where there's two different types of tears. One is partial and one is full. If you have a full tear, something like a stem cell therapy is unlikely to help you. However, if you have a partial tear, stem cell therapies can be very helpful and help you avoid surgery for something like that. So hopefully that helps answer your question, Aaron. For Jill M from area code 514, does this help with knees with arthritis? So again, very helpful. This is unlike steroid shots and gel shots. It's repeatable, it's natural, and can help you avoid that repetitive every 3 month, every 6 month shot. John M. from 518 said 65-year-old with bilateral meniscus surgery many years ago, now needing occasional steroid injections to relieve pain, just like we were talking about before. This treatment is slowly becoming ineffective. I'm assuming meaning the steroids. When that's fairly typical. A lot of times when we see people getting repetitive steroid injection, I like to use the rule of threes. The first one's great for 3 months, the second one's great for 3 weeks, and the last one's great for 3 days. And then pretty much after that, you get no relief. What's interesting here is in you, John, that you've had bilateral meniscus surgery. And what unfortunately meniscus surgery means is that you're either trimming or cutting part of the meniscus out. Studies have shown that if you undergo a meniscus surgery in this way, it actually accelerates your arthritis of the knee. Sometimes that is something you don't always get to know or hear about prior to undergoing meniscus surgery. So it's not really a meniscus repair, it's more of a meniscus trimming. The stem cell therapy is very effective in knees such as this, and especially if you're trying to avoid further surgery, especially that knee replacement. For you, John, again, consultation would be an important aspect of understanding exactly how degenerated is your knee and whether or not we could help you. Thomas M.S. from area code 518, how does stem cell and PRP work to alleviate a patient's pain? So this is a more broader and general question. So for you, Thomas, I'm not entirely sure what we are going to be treating in you, but here is a pretty good explanation that I like to utilize. So if you think about arthritis, which is mostly what stem cell and PRP is used for, we're talking about a degenerative condition, and this could be degenerative condition of the back or the neck or the knee or the hip. And we know that year after year, it's getting worse. And this year is worse than next year. And if we do nothing about it, next year is going to be worse than this year. It's much like this building in the background where you can see it starting to fall apart and deteriorate. What actually causes the pain is not so much the building falling apart, but it's all the debris that has come off of the building. So if you can imagine what stem cells and PRP do, is that it helps clear the debris. Your building might look the same, but if the pain causing debris is no longer there, do you care what your building looks like? And a lot of people would probably say, no, I just want to be functional. I don't care that my knee looks arthritic. I just don't want to feel arthritic. And that's exactly what stem cells are about. With this method, we're talking about something that is minimally invasive. You will have a much shorter downtime than any surgery out there. You're talking about a much quicker recovery measured in days, not months. And we're talking about no scar, no unsightly scar, no loss of body parts, no artificial parts to be introduced into your body. And we're talking about something that's not done in a hospital, done right in our office. And that's how we've done it for 10 years. I hope I say this right, Fidel, last name B, or last initial B, area code 514, said back pain and arthritis. So yes, yes, and yes. Arthritis is one of our most common diagnoses, and low back is certainly one of our most commonly treated areas. Again, talking about something non-invasive, non-surgical, stenosis, degenerative disc, sciatica. A lot of these are going to be the terms that you hear described about your back or your arthritis. Yes, that's exactly the type of people we help. Beverly F. from area code 401 said, I'd like to have answers for dealing with pain. Doctor recommended Tylenol or Motrin, neither help. My orthopedic doc put me on meloxicam, which does not touch the pain. So this is a good example of severity. So regardless of how your knee looks, Bev, you're talking about something that sounds like a pretty significant impact into your quality of life. And in our pain solution, we're without surgery, without medications, we are that third solution. Obviously, with you, Bev, I don't know what we're treating, where this pain is, but that's where the importance of a consultation comes into place. And for you to come in and tell us exactly what it is that you're feeling, and of course, what you hope to achieve out of all of this. Steve N from 514 said, how my degenerative disc disease is affecting my ability for movement and leg weakness and hip pain. So this is a really great question in that we want to know how it all works together. And then therefore, if you want to understand how it all works together, how do stem cells help all of that? So when we hear about degenerative disc, we're usually also talking about stenosis. If you can imagine that nerves pass through canals or through a tunnel, canals that narrow mean that the nerves are being impinged on. Stenosis typically is very limited treatment options. It's either fusion or try to bore out the tunnel, the canal. But of course, if the disc continues to degenerate, you're talking about a losing battle. The addition of arthritis in a lot of this means that your pain is typically increasing as well. What we're trying to do with regenerative medicine is hold that canal open better so that you have less effect from the stenosis. So you have less effect from the arthritis, less pain from the degenerative disc. And we're talking about something with, because it's non-surgical, something with incredibly high benefit and then low risk, which is, again, going back to our goals as patients and as doctors, what we really hope to achieve for ourselves. Lilia R from area code 518, PRP versus prolotherapy. So this is a good question. So really both of them, PRP and prolotherapy, are forms of regenerative medicine. We do both in our office. PRP is something that comes from your blood. It is taken from your blood, processed out of your blood, and then utilized as the therapy. Prolotherapy, PRP is a form of prolotherapy, but prolotherapy can also be where we are simply taking something like an anesthetic, like lidocaine, and combining it with a dextrose solution. So we're talking about just a simple chemical compound of sugar dissolved in water. And we can utilize this in a number of locations. It's the spine, the joint, the tendon, the nerve. Question here is, what are we treating and how severe is it? So PRP versus Prolo is a great conversation, but then begins to separate based on the severity of the problem. So is it a mild problem? Is it a moderate problem? Right? Is it that green, the yellow, or the big red circle? And so different things for different problems, essentially. Gina J from 518 says, to see if stem cell therapy can help with spondylitis and bone-on-bone shoulder pain. So yes, stem cell therapy works incredibly well for spondylosis and spondylitis. And two, stem cell therapy is also very effective for shoulder osteoarthritis and BOB, meaning bone-on-bone. We have, touch wood, not had a shoulder fail on us for bone-on-bone in the last, I want to say 3 to 4 years. So we've had quite a bit of success with shoulder arthritis. We have obviously the next step would be a consultation to review both. Certainly, even though you're bone on bone, and I want to see how much motion is limited. How limited are we in terms of in our functional capacity? There are two very different protocols, so don't think that just because we can apply one, it'll apply to the other. They do have a very different treatment protocol. Elaine D from area code 518 asked similar question from before. How my degenerative disc disease is affecting my ability for movement and leg weakness and hip pain. So again, if you have degenerative disc, it means stenosis, nerves that pass through that, and if the discs flatten, the nerves get affected. The nerves control your movement. They control your strength. They control your pain. So therefore, if you're losing that tunnel, you're losing the nerve function, you're losing those things like movement, strength, and pain. Being able to prop that tunnel open through stem cells, through platelet-rich plasma, is the ultimate goal. We're talking about, and again, having done this for stem cell of the spine for 7 years, I can tell you that even though you've got severe stenosis, moderately severe stenosis, this is an incredibly effective way of helping that tunnel stay open for to the tune of 7 to 10 years. Consultation would be what's required next. John S. from 603 said, I've been told I need a knee replacement, and I've heard that regenerative therapy could be a better option. We certainly think so, but we're also biased, and we've been doing this for 10 years. I think what we often are afraid of, that if we say arthritis, it automatically means replacement, and it doesn't. Arthritis is one of the most common diagnoses for us. We apply that three-step process, MRI included. And we're talking about something that's there for multiple years. Even if somebody said to you, "Look, I'm bone on bone. Look, I'm due to have a knee replacement or shoulder or hip replacement," this is something that can still be effective for you, and not just effective for days or weeks, but many, many years. Don from 518 said, in pain since June, unable to find the reason, back plus plus. So pain is a symptom. We need a diagnosis, and we apply stem cells to different diagnoses. So for you, consultation would absolutely be our next step. Keep this in mind, though. We often use the 30 by 30 and 60 by 60 rule. 30% of the population by the age of 30 shows some sign of degeneration. That doesn't mean that 1 out of 3 people are all experiencing pain, but from a standpoint of degeneration, does show some evidence of that. And then 60 by 60. So by the age of 60, 60% of the population also have that as well. Again, it doesn't mean that 2 out of 3 people are all experiencing back pain. It just means that if we looked, we would find. So based on age alone, you can help even categorize, maybe even stratify what exactly your problem is long before you ever show up. Peter A. from 315 said, relief from extreme lower back pain in the L1 and L2 area, and possible increased mobility for better quality of life for my fiance. So Peter, I'm sorry that your fiance is suffering with this. And the L1, L2 is a tough portion, right? It's just below the thoracic spine. And so the pains that you get are sort of different than what I think a lot of people would say in terms of back pain. It's a little bit higher up. The radiating pains don't always necessarily go down to the feet. You know, sometimes it goes into the hip, sometimes it goes into the low back, sometimes even forward. If anybody's ever said from her low back pain, that degenerative disc and arthritis and stenosis, these are all things that we can help. Spine stem cell experience in our hands for over 7 years. Pretty comfortable with it. And we've been doing stem cells total for 10 years, so quite a long while. Michael W. from area code 51 said arthritic knee treatment, just simply arthritic knee treatment. So knee arthritis is one of our most common diagnoses. Again, similar stem cell protocol with the 3-part series, MRI. We always encourage a physical therapy course afterwards. What I want to know with you, Michael, is are you using crutches? Are you using a cane? Are you using a walker? How bad is the knee? Have you had imaging of it in the past? This really helps us to understand and stratify where you end up in terms of level of success. Russell K. from area code 315 said, what percentage of stem cell therapy outcomes for TOS, which stands for thoracic outlet syndrome, or cervical radiculopathy, have been positive? How many treatments do the above conditions generally take before improvement is seen? Can a patient get the slurry in more than one site per visit? Thank you. I look forward to your seminars. So thoracic outlet is different from cervical radiculopathy, for those who don't know. So thoracic outlet is this sort of section of your neck right here and all the nerves that come out of there. When there is a pinch to that, and this can typically happen from either a cervical rib or from compression through the muscles, it can cause an incredibly painful and radiating symptom to that side. Cervical radiculopathy is something that I described before. It's where the nerve gets pinched through the tunnel as it's exiting. So sometimes it's hard to know, is it actually in the cervical spine or is it in the thoracic outlet? So I would say for you, Russ, it's important for us to know and confirm that diagnosis. Which of the two is it? We do have an incredible high degree of success for both. We're probably one of the few who treat thoracic outlet with regenerative products and procedures. Um, we'll typically see improvements starting before the third in the series. The number of sites that we can inject per visit is limited, and that has to do with a dose dependency. And so during your consultation, we'll review all of that. So hopefully that answered the majority of your questions or all of your questions. And certainly I encourage you particularly for consultation, as you've got some very different and sort of atypical diagnosis. Deb H from 518 said, what are the methods for low back, hip? I'm not sure what in was going to be, but ankle and wrist pain. So for you, Deb, definitely a consultation. Let's understand, is the low back the worst? Is the ankle the worst? Are we just talking about degeneration, or do you have full tendon tears? Or your ligaments in your wrist simply relaxed, or are they generating pain through a torn ligament? All important things that we're going to have to review. So are the pains degenerations? Are they with activity? What sort of activities? How would you describe them? Sharp, dull, achy? What imaging, if any, do you have? This are all the types of information we're going to gather during our consultation. So a lot harder to answer here in a webinar format, but certainly in the face-to-face we can work through. Susan M from 518 said, are there alternative treatments for stenosis? So the answer is yeah. The answer is yes. So stenosis and degenerative disc is usually two things that travel together. Here's a good example of the anatomy of the disc. If you can imagine, the blue is where the disc is, then the cartilage end plate, which I've put a big red circle around, is a very important relationship. And that cartilage end plate then touches the bone or the vertebrae above. The cartilage end plate is how your disc receives nutrition. And for those who are degenerating disc, that means that disc is getting shorter, shorter, shorter. That relationship with the end plate is getting ruined, or it's changing, or it's disrupted. So once degenerated, it is hard for that disc to repair itself, virtually impossible. There are not blood supply, arteries, arterioles, capillaries that go and extend into the disc to help it repair. You rely on that cartilage end plate. So for a lot of people who have started degenerating, remember the 30 by 30 rule and the 60 by 60 rule, that relationship is not going to get better over time. One of the things that we do is by introducing stem cells right into the disc can help reform that relationship. And of course, that's what we're seeing in patients who've gone now, 6, 7 more years out past our stem cell treatment time. Michael W. from 438 said, I have lumbar stenosis, low back causing severe sciatica. So I really like addressing the sciatica question. So yes, Michael, we can help. You already have a pretty good diagnosis. You've got stenosis and you've got pretty good symptoms, severe sciatica. So the sciatic nerve is something that travels through the tunnel, much like the tunnel and the canal relationship I talked about before. If you improve the stenosis, you're going to be improving that nerve function. Now, I do need to mention that not all sciatica and not all nerves can be helped. When can I not help that? When it becomes permanent. But when it becomes permanent, it doesn't matter if it's stem cells, platelet-rich plasma, surgery, medications. There's nothing that helps revive permanent nerve damage. Well, how do I know whether it's permanent or not? So a couple of things that are important to us is number one, whether or not you've had it for a long period of time. So we typically like to say 5 years. Number two, whether there is a wax and wane component. Is there a portion where the nerve pain goes away? Nerve pains can come back, and there's sort of this up and down undulation of the symptoms. Sometimes that to us says, look, this nerve has signs that it is completely normal at times and then abnormal at other, and then therefore it's unlikely to be a permanent dysfunction. Sandy Q from 518 said treating sciatic nerve pain. So similar for you, Sandy. Yes, we can help, but a little bit less obvious than the prior person because we don't know where for you that sciatic nerve is being affected. Is it being affected and because of the lumbar stenosis, or is it somewhere further down the line? So if you can imagine the sciatic nerve is a wire running underground, the wire can change a signal depending on interference, whether it's a tree root or damage or degenerative disc or arthritis or stenosis. These are all things that we want to know. Matt V from 315 said, I need information on knee pain. Are you covered by Medicare? So the first answer is knee pain works well. Diagnosis is important. Consultation is important. And hopefully the previous slides was informative in terms of how we help knee pain. The second question, unfortunately, insurance does not cover these types of therapies, and that's one of the shortcomings of commercial and government covered insurance and care providers today. We hope someday that'll change, in which case everybody has better access to these types of therapies. But as of now, unfortunately, that just doesn't exist. Pinky M from 518 says, what insurance policies does your insurance accept? How much is the consultation? So we are a direct pay practice because, as I mentioned before, insurance do not reimburse for these types of care. And so unfortunately, no insurance policies are covered by my office. To answer your second question, consultation is free. So hopefully that can help answer that for you and at least get the conversation going. Christine K from area code 603 said, how many procedures are needed? What is the healing time frame from each procedure? What is the percentage of positive results? Of the positive results, how many patients get back to full use with no relapse? No pain relapse. What are the odds of relapse and what are the risks of treatment? So Christine, for you, I'm not entirely sure what we're treating. So how many procedures needed and what is the healing time going to be different for, say, for example, neck versus low back, hip versus knee. So these are things that can vary quite significantly. Percentage of positive results depends on whether or not you've had surgery, depends on sometimes the severity, less to do with the age of things. After PRP, I can give you some generals. However, after PRP, recovery is typically 1 to 2 days. Typically, after stem cells, that injection number 2 in my timeline, typically about 4 to 5 days. Results again depend on the area treated, severity, how functional are you, how athletic are you. Some of the risks, so I say this and I'm going to say this quickly. So there's always, anytime anybody puts a needle in your body, you'll run the risk of injury to nerve, vein, artery, muscle, bone, tendon. You always have the risk of infections. And so these are just sort of everyday standard risks. Specifically with stem cells, there isn't anything additional beyond that, as the stem cells do come from you. So you cannot grow a tooth in your knee or your back. That's not going to happen. In fact, we've had longevity studies, not done by me, but by those much smarter and elsewhere who followed people for over a decade now, and nothing's ever grown anywhere. So, which is obviously a strong plus. Judy S. from 315 said, my husband has been treated for hereditary neuropathy in feet. Nothing has worked. Tried many treatments, no headway. feel he had good care but not working. So neuropathy is a symptom. And it sounds like if you've got a hereditary neuropathy, that's probably your diagnosis. I'm probably going to need a consultation, but I will tell you, similar as I said before, that if the nerve damage is permanent, stem cells surgery medications will not make a difference. You can have some medications that might lessen the symptoms, but the hopes of trying to revive that nerve through stem cell is unlikely if you've had permanent nerve damage. So Mindy C from 315 said, I'm a type 1 diabetic for 32 years, have gotten trigger finger repeatedly in both hands. I don't want to do any more surgeries. Could this help? So yes, trigger finger can be helped with platelet-rich plasma, typically a series of injections. All right, so that's the end of it. So if you have a question, please type into the Q&A section, and then I'll try to answer them here in order. But here's my offer to all of those who have decided to attend today's webinar. If you call Friday by noon and you mention webinars, the consultation will be free. For those who want to watch future webinars or have somebody else who'd like to watch this, February 26th is our next. Phone numbers here, 518-871-9900. And for our folks north of the border, 514-697-8919. You can learn more about us at richardkimmedicine.com if you haven't yet, /webinars to watch any prior webinars, and /MRI if you're interested in obtaining an MRI first. So that offer stands to everybody out there. Let me see if there's anything in the chat. So nothing in the chats yet, and I'll hang out for just a second. If you've got something to ask, happy to answer for you guys. Question coming in. Question from C. Would it be beneficial to have an MRI prior to consult? Yeah, that's a great question. So when it comes to information, having as much information as possible is always helpful. Getting an MRI nowadays is not always the easiest thing. So depending on where you are, how easy it is for you to obtain, I would say yes and no. If you know that this therapy is going to be for you, we'll obtain our own MRI to begin with, and so that's not always necessary to have the MRI beforehand. If you think you've had a fairly new pain and don't have a diagnosis, then having an MRI beforehand will certainly contribute to a lot of the information for me to help synthesize and develop your treatment plan. So sorry, C, not a straightforward answer. If you're interested in having one beforehand, certainly we don't discourage you. But it is part of our process and our protocol to obtain it all the way through, and include it in the cost of it. So hopefully that can answer a little question for you. Carmen. Carmen said, are the 3 shots all in the exact same spot? That's a really good question. So yes and no. So example for a knee, we will be injecting the same spot every time, but we'll also be injecting additional spots throughout that process. So not every injection is one injection. Different injections require different things. And almost always we do an intra-articular portion, for example, in the knee or a hip. For the spine, completely different every time. And so the protocol, even though timeline might be similar, what we inject when is very, very different. Second question from Carmen. I had an MRI 1 year ago. Do I need a more current one? No, because if you've had one a year ago and not a whole lot has changed, bring that. I will want to get a new one in our office, so we'll make that as just part of our process. So if you do have information, great, similar to what I answered to foresee before, but don't feel like you necessarily have to get one because likely the one from a year ago is going to show me, or at least give me a good idea of where my injection targets are going to be. For me, MRI is not so much about the diagnosis, it's more about helping me figure out where to place the needle and place the injection. If you know, I've been doing medicine for a little while now, so 85% of the time by the end of our conversation, I already know the diagnosis. I already know what I'm going to see on MRI. The MRI just helps me define, is it two discs or is it three discs? Is the knee more degenerated on the right side or on the inside or the outside? So the MRI is not so much for diagnosis, but more for targeting and location. Any more questions? Okay. The offer stands. Certainly call by Friday and you know your consultation will be free. Otherwise, look forward to seeing you guys and thank you for taking the time to listen to me talk about my obviously my favorite topic, regenerative medicine.